Dr. Diane Adams is Chief Health Strategist who has worked with many organizations, including United Nations, APHA, NIH, and Homeland Security. She is the editor of the best-selling book, Health Issues for Women of Color. She received her Master in Public Health from Johns Hopkins University and MD from Rutgers University. I should acknowledge her because this is her anniversary, and she did us a favor by accepting my invitation and joining this panel tonight. Our second panelist is Denise Everson, who is a consultant at Connecticut Green Bank in Washington, D.C. As an architect and advocate for Design and Health, she has worked with American Institute of Architects and D.C. Housing Authority and AIA National Design Health Leadership Group. She received her Bachelor of Architecture from Hampton University and her Master in Public Policy from Georgetown University. She received AIA Associates Award in 2016, and some of you may know that she has been very supportive of our Design Health initiative, and especially our application for Design Health Consortium. Our third speaker panelist is Dr. Amber Trout, who is the Senior Manager for the Race, Equity, Diversity, and Inclusion Initiative at NeighborWorks America. She received her Master in Public Health from Drexel University and her interdisciplinary Ph.D. in the built environment from the University of Washington. She has widely contributed to our Design Health initiative, and she is very popular among the students in that class, so they love her. I do have a list of questions, and I will be sharing them with the panelists, and they will be answering them, and they will be sharing their comments and suggestions. And obviously, my hope is to give the audience some time for question and answer. So first of all, the whole thing obviously is going to be focused on the main question of this panel, which is public health and architecture and interdisciplinary dialogue and collaboration. So my first question for all three of you is that in your career, have you had close collaboration with architects or public health experts, people in other disciplines? And if so, can you share the results of these collaborations, and what are the common dilemmas in such collaborations?
Good evening, everyone. Thank you so much for having me here. To answer that question, that's a really, really great question. So the Affordable Care Act has made it possible for many communities, especially distressed communities throughout the nation, to secure interdisciplinary teams to address critical issues, health issues among populations that really, really need extra attention. So there are community health assessments that are in many cases mandated through the Affordable Care Act, and those community assessments, health assessments, ensure that communities that are distressed, communities that have challenging health issues, that those challenging health issues are included from the beginning of the planning of a project. So strategies are developed throughout the planning, the architecture planning of a project to ensure that health disparities are addressed. So from the beginning, you can see a public health official, you can see a dentist who would like to relocate in a distressed community. You can see doctors, you can see people who are nutritionists. So the design teams today look a lot different than they used to 10 years ago. And public health officials in a variety of fields are present at the beginning of our planning, the very beginning, the charrette process. So that's something that I have noticed just looking back and working in architecture.
I come at it from a public health community lens. I think collaboration on paper is great. It's very hard to do over time is what I've found in my interactions. In the projects I've worked at, specifically one that I can speak to is I worked in North Seattle, and it was a community wanting to vision what they wanted. There was land, and just getting a common language and a vision in a multicultural neighborhood that was maybe once predominantly white is really hard. And so keeping to the terms and then having the energy to say to the terms, like, what does equity mean? What does a pretty neighborhood mean? What does it mean for me? What does it mean for someone living in a rental housing? What does it mean for someone in an affordable house? That's the part that makes collaboration, constant dialogue important. So that's just one thing I think is important as we keep doing, like you're saying, like the health impact assessments that bring the different disciplines, is how do you dialogue and kind of sit in the discomfort, but knowing that means you're going somewhere. So that's kind of the dilemmas of collaboration, but also because you're sitting in the uncomfortableness, that's where the creative part comes, and really community-informed design blossoms out of that, because you're willing to sit in there and not come in with your with what you've learned in school, right? You're elevating from all the different disciplines of the residents.
Good evening. Before I begin, I would like to thank Dr. Akers, who called me and invited me to this presentation. And when he told me the date, I said, April 11th. I said, are you kidding me? I said, that's my anniversary. So he said, well, Dr. Adams, can you make an exception? So I did make an exception to join you all today, and I'm very happy to be here. I come at public health from a different perspective. I am a retired Commission Corps officer, so normally when I'm presenting or asking questions, I will ask the students, do they know what the public health service is? Let me see a show of hands of students in this room who understand what the United States Public Health Service is. Very few. So I invite the faculty members to educate students about the public health service so that they can apply after they finish their different professions, whether it's medical, dental, law. You can apply and join the public health service, because we need all of you all. I finished Rutgers, New Jersey Medical School, did a family medicine residency from Howard University, and then I decided to go to Johns Hopkins because my mother wouldn't leave me alone. My mother was a nurse, worked at Cook County Hospital in Chicago, Illinois. I'm originally from Chicago, Illinois, and my mother said, well, go to Hopkins and get your Master's of Public Health degree. And she says, and do something that people normally don't do. She said, you have to be a thought leader. And I said, oh God, I'm married and have one child, and she won't leave me alone. So I was accepted to Hopkins Masters of Public Health program, and I did listen to her. So my Masters of Public Health is in Occupational Environmental Health and Public Health Administration. And then 3 other doctors decided that they wanted somebody to participate in the Durham Preventive Medicine residency, because they had not had an African-American woman. So I'm the first African-American woman to enter the Johns Hopkins Durham Preventive Medicine residency program. So I say all of that is that I look at public health differently, because public health to me means prevention, okay? Public health to me means interacting with the communities. It doesn't matter what community you are, whether it's local, state, federal, it means interacting with the community. So I come at public health from that viewpoint. Now, to answer your question, in terms of tying it all together, when I was director of minority health for the Agency for Healthcare Policy and Research, which later changed their name to Agency for Healthcare Research and Quality, I decided to create a proposal. And with this proposal, I wanted to create minority research centers throughout the United States. And Tim will tell you, with that proposal, we were able to create 11 minority research centers. And what's good about those minority research centers, because you know what? They focus on the community. So for example, if you were at Harlem Columbia Hospital, you looked at HIV/AIDS and infant mortality. So if you were at the University of Maryland, Baltimore, you focused on adolescent pregnancy. And some of the other hospitals, Harry Medical, Hospital, Morehouse University, University of California, San Francisco, University of California, Los Angeles, the Pacific Islanders Institute, University of Mexico. But the point is that we need to look at public health from a multicultural perspective. And cultural diversity and cultural competency is very important to me. So that's how I look at public health. From all communities coming together, we collaborate, and prevention is a key to better health care and quality of life.
So Amber, you mentioned the health impact assessment, and that was actually one of the questions that I wanted to ask. Is HIA, the health impact assessment, becoming part of the design and planning discourse or processes? And how can it influence policies for professionals in the fields of architecture, urban planning, landscape, and public health? So you guys do it in public health, right? But it's not very common. So what's your observation of that?
I think the health impact assessment's been around about 10 years, and it was coming out of the CDC when it started developing the built environment discipline in public health, looking towards urban planning and architecture. So it was very interesting how you were learning about the built environment, but still through the lens of a public health practitioner, where you have your medical model. And what I've noticed as more come to address maybe a freeway, placing a school next to a freeway and health air, worrying about the air quality and students and asthma rates, you also need to honor the point of view of the designer and the urban planner and hear their narrative and honor how they address the situation with a health impact assessment. Because I think there's important to address the quantitative that you could catch with the preventative of the diseases, but there's also the holistic of, you know, when you talk to the community, they're like, it's just there, it just feels, I like these attributes. And that's where you really can lean into the design and urban planning background to help assess what that feels like too, that placemaking layer. So I think with the health impact assessment, you're starting to see the timing of when you put it into the decision-making process. So I know that's how it was created. How do you influence a decision? You don't do them randomly. You know a decision's going to be made. And I think students are learning how to leverage that and find that point, because you need to make sure when you do it, you're actually working with the decision makers and bringing up the point of view of whatever community you're working with. To be honest, to reflect on what you were saying, to have that racial equity lens, you just can't come in as professionals and assume you know it's right. And that's what the health impact assessment, I see that's kind of the next evolution. How do you center racial equity as you're doing these assessments, instead of always being professional-led?
The good news is that our Design Health students are working on a project which has to do with health impact assessment in communities around Morgan.
I like to answer that question as well from a public health medical viewpoint. And one can look at design from many directions, okay? You can look at design from physical activity, from environmental health, from sensory environment. But let's say that we could look at a design from physical activity. We now have where you can take a bicycle. How many ride bicycles? You can take a bicycle and you can place certain equipment in the bicycle which monitors your heart rate, your respiration, all of your vital signs. And this is good to know. There's one company in Baltimore, if you didn't know that, is LM Motors, and they are working on the bicycle aspect of design, and they're working with Juxtopia. And Juxtopia, do you know Dr. Doswell, Dr. Gharipour of Juxtopia? Okay, Japhus Doswell is the president and CEO of Juxtopia. So they're working on this design. Their headquarters is in Berlin, Germany. So that's from a physical activity aspect. And also, you can look at design from a smart home. And then who knows what that means. I like to call on students because I taught physician assistant students from the George Washington University, graduate students at the University of Maryland Eastern Shore, and fourth-year medical students from Howard University. So students will find that I call on them. So what student in the audience since you all deal with design, can tell me what a smart home is. Don't all stand up at once. Okay, so you have no idea what a smart home is, okay? Are there faculty members here of those students? Raise your hand. Nobody want to own the students. Okay, well, oh, I saw you in the white sweater. Okay, yes, you. Well, we can have smart homes, and the smart homes about design, and these two ladies can attest, they can agree with me, I believe, is that you can be in a home, but you can also have the monitoring going on in your home if you're an older person. And, you know, the same thing I talked about with the bicycle, you can have other things in the home. Amber, what other things you can say in a smart home that you can have? You know, that you're monitoring people's condition.
Well, I mean, well, the smart home, when I was at Drexel, it was also like consumption and what you're eating as a way to do your diet, what you're throwing away, walking around, so the safety of aging in home as a smart place, intersection of how you age in your home and the importance of design and those cues.
Right.
So there's a lot of, depending on the scale, I think is what is really emerging out of health impact assessments is you have to ask at what scale, because if it's the home or a park or regional, it really defines on how tight you start focusing on the medical, like that health behavior or disease that you want to.
Exactly.
And I think that's really great that you were pointing that out to really nail it home, because I was only speaking more from like a community level, but I think you might also have comments on the design, or Denise?
I wanted to ask Denise if the health impact assessment has been part of conversations at the Design+Health leadership group at AIA Washington, D.C.
So health impact assessments are very critical and often discussed in the boardrooms of AIA. AIA is, interestingly enough, committed from a financial component and from a staff component to design and health. So it's something that has been discussed for years, and I hear it often. As I mentioned earlier, health impact assessments are very, very critical in designing today. So just when teams gather and they are planning charrettes, it's very, very important to, when you're doing a site analysis, to also conduct an analysis of the community that you're designing the site in.
I know that they have their own, they are developing their own version of that, which is called WELL, right? W-L-E-L-L. So my next question is, what are the most urgent areas in which transdisciplinary collaboration between architects and public health experts is needed? I know there are so many things that...
Okay, so, that's an excellent question. So thank you for raising that question. But what I see here, the most important areas is collaboration. And if you're not aware of Clinton Global Initiatives, how many are aware of Clinton Global Initiatives? So this program was established in 2005. And what they do, their meeting last year was in New York, and they have a host of speakers. And these host of speakers come from around the world. They're entrepreneurs, they're thought leaders, and they come around the world and they collaborate with what is relevant in their communities. For example, if you talked about Ben Affleck, I hope I can pronounce his name right, he was interested in the Congo, okay? There was a young lady, she was an entrepreneur, and she came up with a design of how to have sky cabs, CABS, in her country for women who didn't have transportation. So to me, I look at all these speakers who collaborate across world countries, and I brought some statistics just so you'll know that from 2005 to 2016, and I always like to educate our students, the Clinton Global Initiative members have made more than 3,600 commitments to action, and which are improving the lives of over 435 million people in 180 countries. And how did they do that? They did that by collaborating with the different groups. They did by collaborating, let's say if you're a banker and you have an interest in public health and you bring something to the community, or you have an interest in diabetes or hypertension or cardiovascular disease. All of this was done by all of these people in different parts of the world saying, I want to do something of a call to action to help the communities worldwide.
Really depends on the context, right?
I think it absolutely depends upon the context. Once every 20 years, the United Nations holds a housing summit. They held the housing summit in October, I believe, in Ecuador, Quito, Ecuador. I went on behalf of the American Institute of Architects, and it was a wonderful experience because at that Habitat 3 housing summit, it was made clear that it's very, very important to include the communities and the community members. They often know what the issues are. So asking them and not telling them changes the whole dynamic.
Actually, I think that's a really good point. I can speak at more of a local scale in terms of critical trends, and I think the theme is accurate. It's really getting that community voice in there with allowing innovation, not having predefined how the outcome has to come, which is where we're hearing the community knows, and they know how they want to solve it too, so your job is there to facilitate it. One thing I think is a trend, but I think emerging with the two intersections, is how that community voice is used. Are you using it as ornamentation, as a checklist? How far does the community voice go in your process? At what point do you kind of lift up your head and make sure, wow, we've been doing a lot of interdisciplinary work just within our walls. Let's do a gut check and go back out to the community. Or maybe have that community resident or leader on your design group, on your HIA, whatever your project is, but have their voice there. But the next level is understanding what that experience is, just like design-oriented thinking, like when you're trying to think, how would I use a phone or how should I design a park? What was that experience of the resident coming into a meeting? What work do you need to do to make them feel comfortable? So they're really giving their wisdom, not what they think all the experts want to hear. And I think that's the next trend with understanding racial equity and community voices, the how. How do you go about doing that? And who are gatekeepers that may be in the process that limit or make someone feel like they can't raise their voice when you're engaging with the community? Or make it hard just to come, like, do I need daycare? When am I offering my meeting? So little details really matter throughout the whole process, and making sure that whoever you're working with, I've really learned we have a network of 250 organizations at NeighborWorks, is that the community needs to see their words in the product. So that's the important part of constantly checking in and having that feedback loop. So I think that's what I feel the trend is, from taking what you're hearing at the global scale, what the trends are, all the innovation, and how does that actually happen at the local level?
Talking about the community engagement, what are some of your best practices or lessons learned from engaging communities and mitigating disparities, especially in the field of design and health?
My first reaction, that was a great question. My first reaction, so as a design and health advocate, and recently I was with the DC Housing Authority for nearly 7 years, we often had community meetings. So determining what time of day, sometimes you have to have two meetings during one day, one during the day for seniors who don't want to come out in the evening, and one in the evening for parents who work. Also having daycare there, serving food at every single meeting, and not serving food that is unhealthy, but taking that opportunity at the meeting while serving food to give healthy options, having bananas and apples, grab fruit that can be grabbed and held during the meeting, having bottled water as opposed to high sugary flavored drinks. So making this from a community planning standpoint, me being the person organizing the meeting, just making better decisions from the beginning and practicing what we preach.
Actually, I'm going to keep building on with what both of you guys were saying with community engagement, with prevention. I think it's also an opportunity to think of, wow, I've been working with this interdisciplinary team and public health practitioners. How can I co-locate? So while you're attending a meeting, you can also maybe get a diabetes screening or diabetes education, or your heart monitored, or how do I get access to pre-K education, or how do I qualify for different services. So I think it's just another opportunity just to treat the holistic person. And I think that's part of prevention. I want to keep hearing you say, how do you be innovative, right? And yet honor what's going on in the community, recognizing that they have a life and you don't want your project interrupting it, because it's to enhance the quality of life.
So when I talk about community, I try to interact and get everyone involved, okay? So we can start with the middle school. Most of the time, I work with the high school, the college, and what I try to do is engage them into interacting with people in the community. Now, a lot of times, you all may not know, but people forget older people, and I'm an older person. So we need to reach out to, whether you want to call them baby boomers or senior citizens or seasoned individuals. I think that we need to be engaging them in what we do and ask them, you know why? Because they have knowledge, they have intelligence, and they know what has been going on in their community from day one. And just like these ladies said, you don't go in a community, well, at least I don't. You don't go into the community and tell people what you want them to do. You ask them, what is relevant in your community? And then they will tell you, well, we need to go to the doctor, but we don't have transportation. Okay? And a lot of times people, you know what they forget? They forget rural America. They forget rural America. The rural population is very important. My grandfather, he's been deceased for years, but he lived in a place you all never heard of called Villa Ridge, Illinois, on a 100-acre farm, and 40 miles from the hospital, 40 miles from Southern Illinois University. But that's rural America, and he was a farmer. Went to the market every weekend, sold strawberries, corn on the cob, okra, and some of these students probably don't even know what okra is. Okay, but that community, it was close-knit, and people in that community talk to everyone. And what I'm trying to say is that listen to the older people, because they have a lot to say. So we not only want to engage the millennials. You know, the millennials are ages 18 to 35. How many are in that group? Raise your hand. Okay. Dr. Akers. Okay. So, and then we have the Gen Z and the Gen Y and all of that. But we have to come together from those ages to the older ages to communicate and educate each other. Does that make sense?
Dr. Adams, my next question is specifically for you.
Okay.
Do you think the architects are responding effectively in introducing public health on a local level?
Oh, you're trying to get me in trouble. Okay, well, to be honest, my answer is no. Okay, on a local level. I think they could do more on a local level, but I don't know whether it's due to funding, research. Because anything you do, you have to have money. And so research is a large component of what we do, whether it's local, regional, or nationally. And so from my perspective, from everything that I read, I wish that the architecturals could do more. And I hope that didn't get me in any trouble.
I have a add-on. So there are some statistics that when I worked in an office every day, I kept on my wall. The Council for Large Public Housing Authorities, they have a website, and that website illustrates the gross disparities that are present among assisted residents or renters versus renters who do not receive HUD subsidies. So HUD assisted renters have 78% higher rates of asthma. They have huge disparities as it relates to depression, obesity, they smoke more, and the diabetes rates are higher. So as a architect sitting in an office looking at those stats and starting a project from the beginning, I'm gonna make decisions that are different. I'm going to not put carpet in any of the units that I've done in DC. I've done over 26. I've never put carpet in not one room. So that helps decrease in my particular community, that helps decrease incidences of asthma. So making decisions on formaldehyde-free material or low or no VOC paint, but making design decisions that are based in sound principles of design that I have to make anyway, but choosing products and choosing materials that contribute to the well-being of the residents, not just reduce their sickness, but actually promotes wellness. So I think that's something that on the design side, a lot of us, we do, but we don't necessarily call it public health, or we don't think that we're impacting public health, but we make those decisions.
Very good comment, thank you. Don't we work well together? My comment is, and I tried not to be political, but a lot of times when we are doing architectural design and public health, we're not, when I say we, I'm talking about minorities. Minorities have to be at the table because most people understand their community. So if you are a European male and you're doing an architectural design in Baltimore, okay, which the population, certain parts are different, or a low income, underserved area, then how are you dealing with that? And so when I reviewed grants over the years, and I still do HRSA and other agencies ask me to review grants, and I'm chairman, I always look at what is being done in the community. And is there somebody from the community on the panel, the board, or whatever you want to call it? And that's very important, because if we don't have minorities sitting at the table, then it's not going to change. You're going to have asthma. You're going to have obesity. You're going to have, smoking. You're going to have pollutants and so forth. So one of the things, and I'm glad that you brought that out, Denise, is that we need to have more minority people, male or female, and it doesn't matter. You could be a Jewish woman, you're still minority, but you need to be at the table interacting with people making decisions. And that's one of the things that, as a black woman, a lot of people in this country still do not accept clinical trials. Because you know why? Because of the Tuskegee incident, okay? And so that's one of the things that we have to be at the table to make a significant impact.
I was just add on to that. So one way when all three of us mentioned bring the community, have someone at the table, this aggregate data lets you know the impact, good or bad, on your design. So if I do put a home in without carpet, who lives in that home? Is it predominantly Caucasian families, or is it minority families? Who's in it? Who's benefiting from this design? Who gets to live in this building? And so that's how you can understand. So there's the intent, where you have the intervention, you want to lower asthma rates, so the design is to put no carpet or formaldehyde-free, as you're saying. But then the impact is who's going in there and how long do they get to stay in that building. So it's important to disaggregate your data when you're looking at how and who do I, even American, Latino, disaggregate, you can know because there's micro communities in each city. So you need to understand the nuance and how you get in there and really make sure it's their needs that you're meeting. Design, health, holistically, just head and heart.
Thank you. For me, as an architectural researcher, it's just amazing that so much research has been done in in the field of medicine and public health and even psychology and other fields that have not been translated into design or the world of architecture yet. And I should specifically admire Kathleen Lane and the Wellness and Health Committee for organizing the showcase every February, because in a way they are contributing to the evidence-based design in this region. They are kind of pushing architects to be more thoughtful, to read, to study other fields before kind of designing health-related projects. So my question is that, are there any new trends in architecture or urban planning to address discoveries in public health? Because, I mean, I used to be an architect, and I know that architects sometimes don't have enough time to read. So, how is this knowledge being translated into architecture? And how does it have to do with the collaboration, again, between architects and researchers in other fields?
So, two comments. Number one, I am a firm advocate that research should not be done for the purpose of research. That research should be done with a end goal in mind, something that I can pull off a shelf and read and understand and use, as opposed to have it add to my extensive book collection. So that's the first comment. I think research should be done with a purpose, with a great purpose in mind, as opposed to research for the sake of research, which is why Morgan was very, why I was a supporter of Morgan, because I feel that the research that will be done here will be impactful. My second comment is directly around just architects incorporate research, but they often are not aware that they're incorporating research. For example, the U.S. Green Building Council, of course, has the LEED building standard, and in the District of Columbia, LEED from 2006 has been it's been a mandate. So it's actually a green building code in DC. So architects have to design for health, but they don't necessarily intentionally design for health. They are following building codes, but it's in the building code. Trends that I see, the Well Building Institute was modeled off of the Green Building Institute. And Well is a standard much like LEED that will be focused specifically on enhancing well-being. It was at its birth, in my opinion, for design for wealthy people, and it has trickled down to the middle and the low. The Well Building Institute they are one of those companies that they have a give back built into their system, and they plan on not just providing the well building system to those who are very wealthy, but also ensuring that those who are not at all wealthy have those research and data point design decisions that are baked into the well building standard. So I see well being what LEED is. I see well being eventually being the standard that LEED is. And I'm happy that both are collaborating and talking to one another. But I see some innovative cities, maybe about 10 throughout, but within the next decade, I see the well standard being baked into the building codes of at least probably 10 cities. So architects will do it, and they won't necessarily know that they will do it, but it's specifically aimed at improving the well-being of people.
Okay, so I think the question you asked, were there any new trends in public health? And, well, for example, Morgan University has a new trend. How many know about the Alzheimer's program that you're doing? Anybody here understanding the Alzheimer's disease program with crystallization and so forth? Dr. Akers? Should be somebody here that you're working with Juxtopia, and this is the first time that, yes, and that's Morgan State University. So that's state of the art. No one has done that. And Dr. Doswell of Juxtopia is working with you all in terms of that patent. So to me, that's trend setting, that's new, okay? The other thing is that when you talk about public health, so if you look at the architecture, the military have some new ideas. So now they're working on, if you have goggles on in the military, they will tell you certain things, eyeglass, goggles and so forth. So there are whole different architectural design from a public health perspective. And I think one of the things I want to say about this is that in order to, and this is not part of your question, Dr. Gharipour, is we need to advocate. Advocacy is very important. Many people don't think about advocacy, but it's extremely important in the community. And so we may not want to talk to our congressional leaders, whether representatives or senators, Republicans or Democrats or independents. We need to stay on them, okay? And I know in the 90s, I used to be a legislative fellow to former Congressman Louis Stokes, who was a Democrat from Cleveland, Ohio, passed in August of 2015. Congressman Stokes, it didn't matter who you were, what you looked like, how you talked, okay? If you send him a letter, he answers the letter, okay? I know. And so please encourage the communities, and I'm talking about the architectural part of it, to stay on your administration, okay? Because funding is not the same, okay? A lot of funding is being eliminated. So we as institutions, and Morgan is a historical Black college university, we need to stay on the administration so that you all have a voice in the community.
My next question is for Amber. How do current zoning laws dampen or help the direction of health and built environment? I know it's a very general question, but they make an impact?
I'll start off. So zoning regulations throughout the country in many cases can be very helpful. So when we're thinking about bike lanes, for example, or right-of-ways, or making sure that communities are walkable, or limiting the number of parking spots in a community. Those are zoning decisions that really impact health directly. So if you don't have a lot of parking spaces in your neighborhood now, you're going to have to figure out another mode of transportation, which may lead to healthier outcomes for you. So zoning, I'm really, really close friends with the director of zoning in DC, and I've spoken to him in great detail about this, so it's really, really dear to my heart. So DC, I know, is a little different than other places because we focus on, we would like to be the greenest city in the country in the near future, and we are making great strides toward that end. But I think zoning, the building code in and of itself, zoning, community participation, and funding and financing. I think those things, when coupled together with really, really good policy from a mayor or a governor or a state legislature, I think those 4 or 5 different components coupled together impact health greatly. And impact health in ways that people really don't realize that they're being impacted. And not to be sneaky, but I think when you don't tell people, it's like feeding a kid. When you kind of mix it up, add the carrots to the smoothie and put some strawberries in it and blueberries, they just drink it. They don't know that they're eating carrots. So it's one of those things where when we sneak it in or put it in or slide it in through zoning, through policy, through legislation, I think it helps us all.
I think to build on that, sneaking it in, but also it's important to realize when it comes to community input on the zoning and when it's being changed, who is at that meeting and reporting about their experience, what community is showing up saying, I want bike lanes, I want to spend the city money for sidewalks or parks, and who will it benefit? Because I think working with the class this semester is like, who will be pushed out? when you start bringing these design element features in because of coding. So I think a good layer is whose voice is being weighed more important when you're changing or applying a zoning code. And then looking at the disaggregated data, like what would really be the health impact on that? Is a bike, I think the trend is, sorry, I'm like tripping over my words. I have so many thoughts in my brain. So you can think about a bike lane, or you can think about safe routes to school. Sometimes that's all you have money for. And if the bike coalition is at that one meeting where they're getting community feedback, that's where the money will go. But if it's a community that doesn't ride bikes, or the priority is really getting kids to school, then you really got to assess how is that community voice being used when making zone decisions or applying zone decisions. So I just wanted to kind of bring that in there, that social equity, that racial equity lens, even when you're applying zoning code or decisions.
And I will add to both of these ladies' comment, because they said it so eloquently. I think that make sure you are aware of the county council. You know, all the, how can I say, counties have county council members. And you should get to know your county council members, okay? Because that's where everything happens, the zoning and all of that other stuff, it happens there. And so if you're riding by and you see a sign that says something weird, and it's in your neighborhood or it's next door, you need to call up your county councilman and say, what are you doing? I do not like this. And when is your next meeting for the county council? And they'll tell you, and I'm going to be there and make sure that you are on the, what's the word I want to use, that you are allowed to speak. Because sometimes they'll ask you, they'll give you, well, they may not let you speak if you have not told them in advance. So your voice needs to be heard. And so I've seen too much of this where people put up a sign and they don't know what it is, and then they look at it, and then when it's all done, they have something to say. You're too late. County council members, am I correct, is the way to go.
I think another opportunity is youth. A lot of times it's seniors and youth get left out of the conversation of how to build a community. And one opportunity of being at a university is when you're engaging with the community, you're doing a charrette, have a youth speak out, or youth. That's one thing we, when I was a public health practitioner doing like every health counts, is have the youth come and talk to the neighborhood council of their experience and why they want a basketball court. And perhaps the neighborhood associations would be willing to help buy a temporary basketball court on a parking lot that the park district owns. So sometimes you can't wait for the decision. It's how do you find the little changes so it represents, starts showing the community is showing its representatives, this is what we mean by built environment features, and this is how we want to have physical activity, because they're very abstract terms. So you want to make it concrete, you want to make ownership. So training the leadership, having the youth come and speak out, have them do the charrettes, have students, we had landscape architect students at UW come to one of our public housing and work with the students, say, what would you want on here? They wanted like a football field, a water fountain, a trash can. I mean, it's like 8x8 piece of land, but they at least got to be creative. And then when we could get the basketball court, it's, oh, I am part of this community. My voice was heard. And the sooner you get that in, the more comfortable you feel calling your representative like, hey, this sign wasn't up long enough. I didn't have time to provide input. So I just want the engagement you could do with projects with the anchor institutes such as Morgan State can be powerful in getting that voice in there.
And Dennis, you mentioned the issue of code, right? And I would like to share one of the questions that was raised by Charlotte, our landscape architecture student. Has medical and health research made an impact on building codes? For instance, there's a lot of evidence that points to being in and having views of nature improves mental health. For example, how these studies have made an impact on building codes? I mean, have they?
So, absolutely. I would suggest as a point of reference that you visit the AIA's Design+Health group. They have a page. We've developed 6 strategies that we feel could be useful to practitioners throughout the world. I was happy that you came back to this question because I wanted to talk about street lights. So there was significant research regarding the color of light. And that research was posted on Twitter and passed along, and it was picked up by locales. And some local governments actually changed their street light colors or changed out the bulbs so that the color of the light could be more beneficial to their residents. We all know, well, we don't all know, but their light can be harmful and light can be helpful. So having that research from the research side translate into action, I think is an awesome thing. And there were three components of that. So you have a researcher who is sharing the data. You have a designer who is creating the solution to the issue. And then you have a public policy person or decision maker who is signing off on the check to say, yes, this will be installed. So research has the potential, and in some cases has had a great impact. It has the potential to have an impact, and it has had a great impact throughout cities. And I feel like this happened in 2016. It was a big deal on Twitter regarding the color of light. So look that up on Google.
Thank you so much. I do have more questions, but I think it's the best to give some time to the audience for their questions.
Okay, all right. My name is Daniel, senior here in the architecture program. And when you first began speaking, all of you alluded to it, but Ms. Amber, you're the one that said it. You talked about the collaboration in a meeting being uncomfortable and sometimes tense. I was wondering if you could give an example of what that has been, so I could see it.
There I go, putting myself out there. Let me. So one example I have is when I was working in a community in, I'll just go to North Seattle, was defining like what is healthy and meaning who's allowed on the sidewalk at what time and what activity are they allowed to do, right? And so when you're working in a community, you're trying to understand what the term safe is. And safe means safety in a safe community is different depending on who you speak to. And to be honest, I'm just going to have to locate, I'm a white woman, and I know I've been mentioning racial equity a lot because I understand the privilege that comes with leading with white as my race. And I think the reason why it's tense when you're in collaborative projects, if you don't have the racial equity lens, sometimes stereotypes could seep into why you're designing certain elements. And you know what? What you want to do is that's okay, and you want to lean in and get curious. Like, why do you think about why are you recommending that design? How did you hear it from the community? Check in, make sure that's what they want, and not necessarily. It's really hard to take it not as a personal, like I'm personally a bad person. And so being able to talk out of that discussion, sometimes with collaboration, that's what I was talking about, or how a term is defined. Like equity means different for different disciplines. Some disciplines, like in the financial sector, is money, right? And social equity, racial equity, that term, it means something different for public health. So it's not just necessarily everybody gets the same, it's understanding the starting point. And so agreeing to those terms sometimes means making your discipline take a back seat because you're agreeing on a term that might be slightly different how your discipline defined it. But as long as you have a framework to guide that conversation, that's where the uncomfortableness comes. And that's where I think you get curious and not defend your discipline. So that's what I was talking about, because that's really hard because you're in school a long time, you learn the theory, and then you go into the community. I remember my first health education session, and it is not like what the textbook says. It's you're thrown a curveball, or someone brings their sight dog in, and then the door keeps getting interrupted, and then your poster's not hanging. So how, when you're feeling anxious, keep hearing the voice of the community and sticking to the framework that you have, but also letting it change as you change and blend and really become interdisciplinary, transdisciplinary, instead of just assigning, you'll do this portion, I do portion A, you do portion B. You really want the cross-marination, right? That's what makes a steak really good. You let it marinate for a long time. If you do it for 5 minutes, it tastes the same. It's the same with interdisciplinary. The more you stick in there, the more you can go, uh-oh, they're bringing a building into our community. What do we do? Who do we tap? Who do we mobilize? And then you really get that from cells to society or cells to neighborhood. You have what's happening on the inside of the body. You can think about what is my social connection to the community, and what are the professionals and services I need there. We want to bring in a park. How do we leverage maybe the city planning department, or hey, we got Morgan State in our backyard. Let's get a student to do a charrette on it, or a local nonprofit organization. So then it opens up your mind how to plug in together versus defending space, which is hard.
Thank you. That was very helpful.
Let me just say something from a public health standpoint. How many have heard of the word stress? Now, stress will kill you. Am I not correct? Yes. So one of the things that I tell people is learn how to de-stress yourself, okay? That you may say, well, what is Dr. Adams talking about, okay? But be true to yourself. Stay grounded, all right? Whatever you're doing, you know who you are, okay, from a health point of view. So learn how to de-stress yourself. When you are tense, think about it. Okay, so for example, when I have to give a public speech or presentation, I stand in the mirror, I take my pencil, and I try not to say 50 times. Okay, because we are used to saying and that's a part of our English language. But we must learn how to de-stress ourselves, to feel comfortable with ourselves, and not be so judgmental to other people. Sometimes we look at people and we're judgmental. Why are you judgmental? Okay, why are you tense? So my recommendation to you young men is that you talk about tense, is learn how to work with your level of stress so you can feel comfortable with yourself.
So I've been in very tense meetings, and I do have some recommendations to handle and deal with it. So number one, remember who your client is, and I'm speaking from a place of on the design side. So for designers, for public health officials, for those people who are meeting with the community, remember who your client is, the end user. Number two, pick your battles. Some things you're gonna stand firm on, and some things you're gonna let go. And number three, know the rules and the players. So that really is number one. You have to know who can get things done for you, who you can do things for, because a lot of times there are meetings before the meeting. So I think about working with a developer in the District of Columbia, and that particular developer was new. We worked on a Hope 6 together. I worked on 3 Hope 6 projects. This was my last Hope 6 project. The developer was new and new to the Hope 6 arena. And they were insistent upon putting dining room chandeliers in the apartments because they wanted people to actually have a dining room table and sit. So that was their thing. They wanted to curb behavior and make sure that people sat at the table. And that was something that we didn't necessarily fight. You have to choose your battles. There were other battles for me. I know I don't like people sitting out on the front stoop doing hair, or sitting out on the front stoop doing anything really. So having to put that in a situation where you can tell somebody, hey, there's somebody who lives next to you. They're paying $1,500 in rent to stay here, and then there's somebody who stays next to you and they're paying $1,700 in a mortgage, and you're paying about $125. I'm not gonna tell anybody, but that's what you're paying. So can you just not sit on the stoop and braid hair because your neighbors don't like it? So expressing yourself in a way that people understand without being judgmental, but giving your reasons. And being okay if they say, no, we're gonna sit out on the stoop, and that's just gonna be what it is, and having to find a way to get around that.
Thank you.
I can use my teacher voice. My name is Kim Coleman, and I'm actually a faculty member in the School of Community Health and Policy, specifically in the public health program, trained as a health educator, so yeah. I heard you talk a lot about specific groups of people, and as Dr. Gharipour knows, a group that is near and dear to my heart that I have only heard one person somewhat allude to tonight when they talked about a guide dog. I think you mentioned a guide, is the disabled. And looking at architecture, keeping this very special population in mind and designing for this population. And so what I'm wondering is if you could just share a little bit about one or two projects that you know of that actually took into account bringing together that particular community. I'm talking more specifically about persons who have either intellectual and developmental disabilities.
So from coast to coast, border to border, architects are mandated to design per code to meet the ADA. So a lot of those things just take care of themselves. In such, I'm not talking about the mental or psych. I haven't touched that yet. So let me just finish my comment, please. So some of those things take care of themselves. Other times there are mandates in DC. I know we've been sued a lot, the city. So we had to go above and beyond to make sure that a certain amount of homes had elevators, and not only just accessibility, meeting accessibility standards, but going above and beyond. So those. I think it takes intentional collaboration from the beginning. So when a community does a health impact assessment, and if they identify a significant population that requires a specific strategy to remedy, then they make design decisions to address that. But architecture students are taught universal design. So it is who we are. We design universally. So I'm looking at a stair behind us. I'm looking at two rails on it. So if a child goes up that stair, they have a rail that's their height. If an adult goes up that stair, they have a rail that meets their height. That's universal design. That's what we're taught. It's not. It wasn't mandated. We're just mandated to have a rail to promote safety. But someone somewhere learned universal design because I'm looking at it. And I know at Hampton I learned universal design, and I would expect that they would teach it here at Morgan. I would expect nothing less. So inherently, it's inherent in the architecture profession, it's inherent in the architecture education system that we go above and beyond to make sure that people, no matter their physical constraints, can enjoy the space. Now, mental, psychological, behavior, those are different. And if I were dealing with a community that had a significant amount, if there was a concern of a community that I was hired to consult with, I would include psychologists and psychiatrists and social behaviorists at the table from the beginning so that they could influence my decision. Before I put anything on paper, I would make sure that they were a part of that collaborative team to say, this is an issue that we have in this community, and these are the strategies that we should employ. For example, color. So there are certain colors that trigger certain behaviors. So maybe we should not include this particular color in this particular room, or this particular color in this on this building. There are space and proportions that make people feel differently. So if you're claustrophobic, it's going to affect the proportions of the space will affect you. So designing to take into account those who are different, I think it's important, and we do.
Okay. But I have your answer. Okay. So the person that you should contact, and she has written several books, and if you see me afterward, I'll give you her number. She is a professor at the University of Akron, Ohio, and she has written numerous books on learning disabilities. She has worked with the city of Akron, with the mayor, the county council, and everything that you talked about. And her name is Dr. Bridgie, Bridgie Ford, Ford. And I know her very well because we were first cousins. Okay, so, and we grew up in Chicago, Illinois. So see me, and she has done a lot of work and has received a lot of awards in your area. So when you say you don't know, you can't find the research and so forth, just talk to Dr. Ford. Okay? Did I answer your question? Okay.
I should also mention that in the last 7 years, there has been a lot of work in this field. Not necessarily by architectural researchers, but by psychologists, that is now being translated into design. So the Academy of Design and Health, which is based in Europe, has done a lot. So that's why you can find a lot of facilities, especially in Europe, that are designed based on these concerns, and for that kind of audience.
Thank you. My name is Kevon Jackman, Dr. Kevon Jackman. I'm interim coordinator for the Student Research Center. We work very closely with Dr. Gharipour and the Design+Health Club. So I've been in Baltimore since 2011. I am an avid bicyclist, and I've been cycling around Baltimore through the city for many years, and it really is no joke. A lot of drivers are very hostile to bicyclists. And they come really close, and they come up right behind you, and it really feels not safe at all. So I was very happy when in my neighborhood they added bike lanes that extend all the way from, and it's section bike lanes from like downtown up to 25th Street. There's some that goes east to west, and being someone who, and my local councilman, Eric Costello, he was very supportive of those bike lanes. But I cycle from Bolton Hill to Morgan State University. And while some of that journey is through those section bike lanes, I go also down 33rd, which has a bike lane, but it's not sectioned off, and that is an unsafe area. So, I feel connected to my councilman, but what about if you're trying to encourage people to commute, and they go from these communities which have these protected areas for cyclists, but then they travel to areas which doesn't have that same protection? How do you engage those communities in which that sort of protection for cyclists doesn't seem to be a priority?
Well, what I would say is, I don't know whether you had been here from the beginning, but I think you should speak to Dr. Japhas Doswell, because he is working in that area of bicycle with automotives, and I said that earlier. And so if you need his number, I'll be happy to give you his number. But he was born and raised in Baltimore, Maryland. So he has a good idea of the Baltimore area. So if you talk to him, I'm sure you can work with him and then make some suggestions.
I'm not from Baltimore, but what I can share is kind of my first reaction when I was listening to your story of that you're in a neighborhood that it's protected, then you drive through neighborhoods where it's not protected. And I think one way is, how do you engage the community or your representative is who lives in the neighborhood that it's not protected, and kind of show why is safety not prioritized in that neighborhood, and really understand and kind of dismantle where the money's being spent and why, because the accountability piece is really what pushes the hands. Research could go so far, but when get the community to see the value, that's when it's more the community voice, and seeing, when you look at the data, the disaggregated data, why is it not in that community, and what reasons? I don't know, I would just dissect the decision. There's a lot of power in the who's deciding and why, and how are they connected to the community or not.
I have an actionable item for you. So when you leave here today, identify your council member who is over transportation, and contact their office and ask if one of their legislative assistants can do a ride along with you. So invite them to your home on a Saturday, maybe prepare them coffee and a bagel, or an apple or banana, and ask them to join you and ride from your home downtown so that they can see and not just hear you.
Or at 5 o'clock
Yes.
on a Wednesday.
And one last thing that I should say, and I think we all three of us have mentioned it, but policy is very important. You know, writing policy, we all forget that. So let's try to write policy and figure out the implications of what we're doing. That's very key to people on the Hill, okay, as far as your representative or your senator. So policy is very important. I just thought I would throw that out to everyone.
In Ray Terry School of Public Health, I happen to know two people that's on the panel up there, and I know what goes on in D.C. But I also want to say to the individuals who are here, you got to know that you have advocacy groups, you also have NGOs within your community. It's extremely important to get them involved in that conversation with policymakers. That you just stole my spiel about, you got to be there to make policies. And that's our mistake, especially minorities. We're not there. And decisions are being made, and then after the fact, we start complaining. Now, one of the things we'll be talking about very soon, because I do a lot of work in international work, is that we're talking about architectural design probably in Cuba. Also in Africa, we'll be meeting next week on that. Most of you probably don't know from the international perspective that there's a whole granting process known as the Millennium Challenge Grant. Wonderful opportunities for designers. Look at what they're doing. MCC, and they only give contracts to nation states. But we need some minorities in there to make sure that the policies and the infrastructure that is being developed in these countries reflect the needs of the people of the country, but also the needs here. There are several other grants. We met last week down in the Consortium of Public Health, and the same issue has come up. Where are the minorities? And why aren't they in here talking about what needs to be done from an infrastructure development as also from a design perspective? And I just want to share that with you so you begin to look at things a little bit differently and get involved. Research they're talking about has to be translated into an applied process. We're the only ones that can do that. Okay?
I know we don't have much time, but quick question. First of all, thank you. That was very insightful discussion. Question I have, a little bit controversial maybe, but how do you think the relaxation of environmental regulations impact creativity and innovation to make us healthy? Will it strangle your creativity or it will make you more creative?
Well, let's just go to Flint. We could talk about facts, right? Not alternative facts, but real facts. So facts, when we are discussing relaxing environmental regulations, sometimes environmental regulations aren't relaxed on purpose, and sometimes they are relaxed on purpose. So in Flint's case, they were relaxed on purpose due to lack of funding, or so they stated. When a community, when a state, when a nation does not have clean water, clean air, which in my opinion is a right, not a privilege, then we all suffer. So it is vital, it is important that we, regardless of your political affiliation, regardless of which side of the aisle you sit on, we all have to have some basic things such as air. We all have to consume water. So having those things drinkable and breathable, I think, are important.
You saw me like, hey, you answer it. I don't want to do it. But I think it builds on what this gentleman was saying. That's at a national level. What can you do locally, right? That's where my mind goes, despite like it can be seen as a polarizing question. But I think not to get frozen there, and what can you do locally? Who do you engage? What is your coalition, nonprofit research, resident leader, defining like the term minority or an equity lens? It could be people of all abilities, it could be women, it could be sexual orientation, really kind of opening up that lens and get multiple perspectives on how you can address it at a local level, because that's what you can control, right? And that's where you focus on how you can improve the health. Like if it is water quality, then what is everybody's role? Kind of grounding into collaboration. What can you influence and how can you leverage the money you do have, or the volunteers, or the local anchor institute if it's a university, or could be a CDC or a nonprofit. So I think it's going local and is my first instinct.
Okay, so I know this gentleman and the question that he asked. Okay, look at this as when you talk about the environment and how do you want to make a change. You make a change, and this may be far out. It's like when we have an election. You have to go and vote. If you don't go and vote, then you select someone else, or someone else is chosen, and then what are you going to say then? Are you going to say, I didn't go and vote, so I didn't make a difference, okay? So when you have an environmental problem, whether someone is building a chemical plant in a neighborhood of underserved, underprivileged families and communities, those individuals from the local community should do just like this gentleman said, I said, and all three of us said, is be proactive. You have to be an advocate, okay? It's just like medicine. Okay, if you bring your relative to me and, or not me, I'll choose somebody else, to a doctor or a nurse or a healthcare provider, and they're not doing what you think they should do, then you should be an advocate. You should question the person and say, nurse so-and-so or doctor so-and-so, because, and the reason why I say nurse, in some rural areas, they don't have doctors. They have nurse practitioners. So she or he is the doctor. And so you have to be the advocate for that person and try to do the right thing. So advocacy is very important. To me, it's just like voting. If you don't vote, get out and vote, then you suffer the consequences.
Probably we should not forget about the role of educating the community and also the new generation, who is going to serve as the advocate for all these topics.
Thank you all for your presentation. It's very informative. My name is Rodney Moulton. I'm a graduate of Moke State University at School of Planning, also a federal planner in Washington, D.C., and I teach as an adjunct professor sometimes. Mainly for the students, and graduates too. There's a lot of programs talking about educating planners and architects and about public health, placemaking, being more green, sustainable, and so forth. But has there been any consideration to maybe offering electives or some basic courses in public health and architecture and planning programs in various schools around the country that you know of to educate planners and architects on what public health is as it relates to designing and planning facilities and communities? Because I think, you know, it's a lot for architects and planners to try to understand the various disciplines, and they're not the doctors, they're not the public health specialists, but they need to know these things. Do you think maybe courses or specializations in that area, joint programs may serve some of the students better to understand as they go into the profession?
Absolutely. So that was a great question. If you visit the AIA's Design and Health Leadership Group, the page, the website, they will give you members of the Design and Health Consortium members, consortium schools throughout the country, and they are all promoting cross-collaboration among public health schools as well as schools of design. So in order to become a member of the AIA's Design and Health Consortium, you had to submit one had to submit an application that had a design school and a public health school. So Morgan was successful in that effort because they collaborated, and those courses exist, and they've existed for a while. So Morgan and other institutions have curriculum and templates by which to design courses as well as entire programs and degrees based upon, because other schools throughout the country are doing it, and they're not just schools that are kind of they're literally across the country in every different region, not every state but every region.
Talking about Morgan, actually the course that you are offering is open to planning, landscape, and architecture students. And also the student health club that we have, Design Health Club that we have, includes members from business, engineering, planning, landscape, and different disciplines, both undergrad and graduate school.
Okay, I'm going to say this. As much as I love you all, I have to go. Because today is my anniversary, and my husband is working outside. But I want to make one last comment because I didn't hear anyone use the word mentoring, okay? Mentoring to me is very important. I could not have gotten where I am today without mentors, okay? In the public health service, Dr. Coops, Sarah Coop was my mentor, Dr. Lewis Sullivan, Morehouse University, Dr. Can't think of his name. I just said his name. He was a congressman. Louis Stokes, thank you. See, that's you all have done that to me. I can't even think. And Congressman Louis Stokes, you know, you have to have good mentors. And when I was at Hopkins, I had Dr. Edith Schoenrich, and mentoring is very important. So sometimes it's not what you know, it's who you know, okay? And I would like to see more faculty members mentor students and really mentor them, not just take them and say, okay, you should know about this, you should know about this. Get involved in throughout their life. I have mentees that are now breast surgeon, cancer surgeons, and orthodontists, but I knew them when they were in college, you know, at George Washington University. And they still call me today, Dr. Adams, what about this? And Dr. Adams, what about this? And I tell them, well, you might not want to do that because that's not your part of your personality. But you have to keep it real. So mentoring is very important, and I hope that the School of Architecture and Design start mentoring students. And if you don't have a program, then start it, because these are our millennials, these are our people that, the young people that they have to take over when we're gone. And not only start with the college student, start with the high school students. You know, plant that seed in high school, and if you have enough energy, go to the middle school. Now me, I start with high school because the middle school just seemed like a little bit too much for me. Thank you, and have a good evening.
Thank you so much all for joining us. Thank you.